started, okay? Because I'm very excited to announce our next speaker, Susan Reeves. Susan and I were talking before we started, and so Susan remembers me working with the neurosurgeons, making rounds with the neurosurgeons about 20 years ago,
2022.
20-something years ago. So that's been a little while, hasn't it?
Yeah, it has.
But those are great memories. You know, it was a different time, right? Kind of a different time.
It was different, but it was, still focused on holistic care, teamwork, interdisciplinary teamwork.
So many of our neurosurgery patients desperately needed therapies to get better and improve and reach their maximum functioning ability. So anyway, it was great. But anyway, so I'm just happy that Susan agreed to spend her time this morning to talk with us, because now she is the clinical director for Rehab Therapies at Wake Forest Baptist, and she's just a super asset to our rehab program as well as our comprehensive stroke center. And let me just say one little thing here that AHEC needs. They asked me to remind all physical therapists that want credit to please put their license number by their names at the registration desk. So we want to be sure you get credit today, okay? So, okay, great, thank you. All right, Susan, I'm going to be quiet now and let you talk about innovative therapies.
Perfect. Perfect. Well, thank you, Rayetta. For those of you who've known Rayetta, when I was a brand new therapist and a student at Wake Forest Baptist, was a clinical specialist on the neurosurgery floor. There were 4 nurses who helped everybody make things happen, and it was just amazing. If we didn't know what we needed, we didn't know what the patient needed, she would say, well, let me find out for you. So appreciate your helpfulness then and today. So we're just going to switch gears a little bit, and we're going to talk about rehab. So what happens with our patients after they leave the hospital and they have deficits? We talked about the fact that some patients have minor deficits, some patients have really significant deficits. So we're going to go through some care models for how to address their needs. Our learning objectives is to just revisit a little bit the concepts of neuroplasticity in the context of stroke rehab. So we're going to talk about why do we do what we do, and with our beliefs for neuroplasticity. We're going to explore evidence-based approaches to stroke rehab. What are the models out there that are evidence-based? Highlight the American Stroke Association, American Heart Association guidelines for stroke rehab, explore current technology that's available to our consumers, some things that might be available at home, some things that are available in big rehab centers, and then understand the importance of patient engagement in the context of activity counseling and community lifestyle changes. So we're going to jump into this and recognize that after a stroke, the brain is different than it was before. We've been seeing images of this all morning, and as care teams, we try to kind of build some scaffolding to help with brain recovery after stroke. And from the therapy perspective, we focus on developing new connections. So we've seen damage, but from a neuroplasticity perspective, we believe that there can be new brain connections around the areas of damage. So in therapy, we initiate therapy early, and we focus on frequent and intensive exercise. We have to recognize that neurovascular health is also important in this, and our care teams really focus on making sure our stroke survivors have well-managed blood pressure, and that maybe some of the risk factors that they had that led to the first stroke are modified. So we do diabetes counseling, make sure that cholesterol isn't within range, talk about diet, exercise, and smoking cessation. And as rehab professionals, it's our role and our goal to all collectively address these things together. So we learned today also from Dr. Brown that we're getting better at taking care of acute stroke. There are many quality guidelines that are driving kind of optimal care for what happens when the patient presents with a stroke. But we feel like after the patient leaves the hospital, we have an opportunity to do better. We have lots of evidence-based interventions, but we have the opportunity to really do better and collectively address care from a holistic model, and we're going to talk about that. In that context, we recognize that after stroke, patients have motor impairments in the extremities, the core, and musculature that affects speech and swallowing. Their sensory impairments, so tactile, proprioceptive, visual. Their language-related cognitive deficits and cognitive deficits in general, affecting memory, attention span, calculating abilities. Patients who experience stroke also may have depression, loss of appetite, loss of energy, and insomnia. And I highlight all of this because we're going to talk about stroke rehab. We're going to talk about getting patients up and moving after stroke, but we have to acknowledge that it's difficult. They have lots going on. There are lots of factors that might impact their ability and drive in engaging in rehab. And when we talk about care models, we need to think about models that collectively support the patient. Again, this happens in the acute hospital. Everybody's there. All the care providers are taking care of the patient. Happens in inpatient rehab. There's intensive resources for helping patients get better. But when they leave the hospital, we've seen gaps in care in terms of really holistically supporting patients. And we're going to talk about again, some evidence-based models to collectively take care of the patient. But before we do that, I want to just recognize also that when someone has a stroke, there are acute changes. There's CNS damage that likely leads to paresis, and that can result in the patient maybe not moving as much as they should and kind of quickly developing contractures or other limitations in flexibility. And those things we recognize, again, in the hospital, but there are also delayed consequences. There is CNS plastic rearrangement, a supraspinal, spinal level that leads to overactivity, and our patients with stroke might develop things like spasticity, dystonia, spastic co-contraction. And all of these things, typically that comes up after the patient leaves the hospital. Maybe in inpatient rehab, but much of the time later. So it's important when we're talking about stroke rehab to put in place models that touch the patient throughout their years of being a stroke survivor, not just acutely. So when we think about stroke rehab, we believe that a lot of what we are trying to do, so after a patient has had a stroke, is really work on reestablishing connections to help improve function. And the concept is that neuroplasticity is a basis for rehabilitation and recovery. Neuroplasticity is persistent changes within the central nervous system that result from prior experiences and influence future motor behaviors. And neuroplasticity comes about from brain activation, axonal growth, sprouting, developing new synaptic connections, and protein upregulation. And the goal of rehab is to capitalize on neuroplasticity. We need to acknowledge that after stroke, the system reorganizes. Whether patients receive rehab or not, the system will change. And if you think about a patient, a stroke survivor who is in the hospital and on their way out the door, and then you think about them a year later, it's clear that something happens. The system continues to rearrange. Patients continue to have a progression of deficits or potential recovery, whether we intervene in rehab or not. But the goal in rehab is to help reestablish connections and practice tasks to positively influence neuroplasticity. So neuroplasticity is driven by changes in behavioral, sensory, and cognitive experiences. And again, learning happens even in the absence of rehab. So in rehab, we want to try to drive plasticity in the direction to promote recovery of function. This is a quote from 1949 that describes kind of what we're attempting to do in rehab. It's described from the neuroplasticity perspective that neurons that fire together wire together. So when we're working on helping patients recover or reestablish connections, we want to practice whole activities that are meaningful to the patient, because that's how they will develop the ability to perform those tasks. So this is just an example of someone in an unweighted system to work on walking early on. And we believe that if we practice tasks, that we will help in recovery. So the principles behind neuroplasticity, if anybody can remember their basic science research, we studied the basic science for neuroplasticity is really based on animal models, but these concepts apply to our patients, whether they have experienced a deficit from stroke, or even if we're trying to practice, as high-level athletes, improvement in some performance. So principles for neuroplasticity in rehab are use it or lose it. Neural circuits not used will degrade and change. So immediately after stroke, we want patients to get up and practice the things that are difficult for them to facilitate recovery. Use it and improve it. Training will enhance function, so we want to engage patients in using affected limbs, trying to improve their speech, and then we want to train that over time to get improvements, not just use, but improve. In terms of neuroplasticity and training, we also believe in specificity, that if we're trying to help someone improve at a certain task, we need to practice that task. So the evidence supports that if we're working on improving gait function, we need to practice gait function. If we're working on improving an ADL, we need to practice that specific task. So this is about task-specific training. Repetition matters. Having a patient engage in a task is great and helpful, but then we need to repeat that task over time and many repetitions at times. And then also intensity matters. We need to be intensively delivering exercise and rehab interventions because that best drives outcomes and improvement. Time matters. So principle number 6, plastic changes require process over time and do not alter instantaneously. So we take that to mean, okay, well, if we're working on a task and it's not better today from yesterday, we should encourage our patients that we can get better if you continue to practice. But also there are certain time periods after injury where patients may have the best opportunity for improvement, and we're going to talk about that. Salience matters. So the system weighs the importance of any given situation to facilitate motor learning. So how the patients feel about performing the task, how motivated they are, how much they enjoy it, is important in driving recovery. So that's going to be important when we talk about some of our strategies, because we need to make it meaningful. Age matters. Some of our younger stroke survivors may have the opportunity to recover more than older. So we just recognize that, and that can be encouraging for very young individuals experiencing stroke. Transference, there's this idea that plasticity within one neural circuit can kind of transfer to promoting plasticity in neighboring circuits. But then there's also this concept of interference. So if we're trying to help someone improve at a given task, we want to practice that given task, and we want to be consistent in that. Because if we practice it too many different ways, there can be interference in the learning. So especially when we're teaching caregivers or having patients practice tasks on their own, we all want to be consistent in the strategies. So again, neuroplasticity is why we do rehab. We're trying to drive plastic changes to promote recovery, and there's good evidence that this works. Treatment initiated within 20 days after stroke was associated with significantly high probability of excellent therapeutic response, so it's important to intervene early. Rehab can improve functional outcome, particularly in patients with lesser degrees of impairment. So that's important because Dr. Guzik talked about patients who might have mild impairments. Some of those milder impairments are most treatable. Sometimes we overlook them because they don't seem that bad. But so for example, I worked or spoke with someone recently who was a very high level functioning person who was having some deficits that others might not think were significant, but they were significant to him. So we need to not overlook the opportunity to improve and support plastic changes in anyone, regardless of how minor that deficit seems. And the recovery of treated individuals with communication disorders was doubled when treatment began within 4 months of stroke recovery. So intervening early is important, and intervening with lots of practice and intensity is important. So we're going to talk about some novel ways of taking care of our patients post-stroke. I think we do a really good job, again, in the main hospital and in inpatient rehab, but we recognize that sometimes when patients leave the hospital, they don't get maybe the best services, or sometimes there's gaps in transition. And throughout the state of North Carolina, there has been the COMPASS project, which is focused on pulling together models of care to help ensure that we bridge the gap and connect patients with community resources. So we're going to talk about that, specifically the rehab module of that. But this slide just really outlines that, we have patients in the main hospital. Some of them are fortunate enough to go to inpatient rehab, but then ultimately they do go home or through outpatient therapy. and then eventually into a community intervention program. But ultimately, our goal is to get patients really focused on self-management and taking care of themselves. Dr. Brown talked about the incidence of stroke. There are many, many patients who have stroke, many survivors surviving for longer, and part of the role of rehab is to bridge the transition and get them engaged in ongoing activity and lifestyle changes to promote fitness and health, independent function, safe mobility, and community engagement. So how do we do that? So we're going to talk about Movement Matters therapy model, which is just a model of therapy for community intervention that has been promoted as part of the COMPASS project, which is Comprehensive Post-Acute Stroke Services. Then and a lot of that is focused on self-management for the patient. Then we're going to talk about new technologies to promote stroke rehab, and some of that's really exciting as well, because we have this next generation of really bright biomedical engineers who are thinking up some pretty innovative strategies to help our patients that are engaging. And then we'll talk a little bit about activity counseling and community exercise. So when I talk about Movement Matters, I'm going to talk about just a kind of a way that we message to patients about what's important after stroke. Movement matters. And Movement Matters is just a way of thinking about stroke recovery that was promoted through the COMPASS project. And I just want to recognize that that the COMPASS project was a comprehensive post-acute stroke pragmatic trial implemented throughout the state of North Carolina, and we were fortunate enough to have 4 incredible stroke experts put this together, 2 of whom, or 3 of whom were at Wake Forest, and then Wayne Roseman at UNC. So Movement Matters. Movement Matters is a kind of a messaging and packaging of a program to give to patients post-stroke. And you may say, well, why is it important to message and package something like Movement Matters? It's important because in stroke care, there's been a lot of really good messaging to patients on the acute side. Has anybody heard of FAST? FAST, yeah, so FAST means face, arm, speech, time to call 911. And that's something that, that we all know now. That's a message to patients that if you are experiencing these symptoms, you may be having a brain attack and you need to call 911. And that's kind of new. We've done a good job of really promoting that. So Movement Matters is trying to do the same thing on the back end when patients are stroke survivors. We want them to understand that movement matters. It's important to get up and get moving to address all of the impairments that we talked about at the beginning of this talk, and it really help them best reintegrate with the community. So Movement Matters is a therapy program put together, kind of compiled by some folks at Wake, most importantly Pam Duncan, who is a stroke expert who we're all fortunate enough to work with, and Amy Pasapa at Duke, who is a therapy scientist as well and stroke expert. And the Movement Matters program really focuses on physical activity, exercise, and fall prevention recommendations for stroke survivors. And what is addressed is that early on after stroke, it may be difficult for patients to participate in activities. So we try to build a base of activity, start them slow, progress them, be consistent, and then address falls, risk reduction, foster self-management, and ultimately help them transition into some independent community activity. And I think that we would probably all think this completely makes sense. And some of us have been talking about this for years. However, we know still today that many patients leave the hospital and don't get regular activity counseling and don't get all of these things. So we're going to talk about kind of how we in the room collectively can best counsel patients on some tools that might be helpful. So Movement Matters is evidence-based, and it's based on the American Heart Association, American Stroke Association guidelines for stroke rehab and stroke recovery. The model describes that the evidence supports that when we're rehabbing our patients, we need to be delivering structured and progressive exercises focused on strengthening, flexibility, balance coordination, and cardiovascular endurance. So in a rehab program, we should address all of those things. Physical activity should be included as early as possible into home activities and communities. And this doesn't just mean doing a home exercise program. It means talking with the patient and understanding, well, what can you do? I've worked with patients who may be in a wheelchair and say, well, I can't get up and walk, I can't exercise. Then the question is, well, what can you do? Can you propel your wheelchair around the room? How long can you do that? Can you do it for 5 minutes? Can you do it for 10 minutes? Well, if you can do it for 5 minutes, do that 5 times today. Don't let your wife push you to the kitchen. Do that on your own, and just kind of message about these simple things, because it's incredibly important for stroke prevention and for recovery to message on physical activity. Then we also have tools for promoting graded self-directed exercise, and we're going to jump into those. So it's also important for us to kind of hold ourselves accountable and have checklists to make sure that we're delivering the best possible care. So Movement Matters really describes that every care provider should counsel patients on physical activity. Physical intervention should be structured and progressive. Physical intervention must include strength and balance components. It must include upper extremity and dexterity, as well as fall prevention strategies. And if a patient is receiving therapy, or if they have an exercise program, that patient should be able to go to their primary care provider. The primary care provider should be able to ask these questions, and the answer should be yes. Does the exercise program include exercises to improve my balance, to strengthen my legs, are they activities that I can safely do, and does it challenge me to be progressively more difficult each time? So we've talked about the concepts, things that we know are evidence-based and are important in stroke rehab. Now we're going to talk about a couple tools to get there. GRASP is a graded, repetitive arm supplementary program that is evidence-based and targeted specifically for improving upper extremity function for stroke survivors. And I guess I would just ask, just a show of hands, has anybody seen GRASP, used GRASP? Is anyone familiar with GRASP in the room? 1, 2. Okay, well this is good, because this is new and it's actually very, very good. So GRASP is a program that's been put together by our colleagues in British Columbia, and it is a homework-based program that should be driven by a physical therapist or occupational therapist, a therapist. It is available to everyone. All of the resources are available online, as well as videos to help the patient engage. So there are instruction and patient manuals. It's safe. It promotes upper limb use outside of formal therapy time. It does prescribe that the patient should participate in 1 hour of upper extremity activities daily, and it requires active shoulder shrug and wrist extension movement to be able to participate. So when we think back to engagement, when we're trying to get our patients who are struggling to engage, we want to make sure that they can be successful at the task. So it's important to recognize that you do need to have some minimal upper extremity function in order to participate. We know that nearly 3/4 of stroke survivors experience upper extremity symptoms after stroke. Management of the upper limb after stroke is complex, and we need a combination of strategies to address complications, recovery of function, and compensatory strategies. And there is consistent concern that patients, stroke survivors, don't receive enough intensity and dose of rehab therapy after stroke. So it's really nice and important that this is a program that stroke survivors can do on their own with just some minimal guidance from rehab therapists. Research supports that it takes hundreds, thousands of challenging repetitions of practice to improve reach and grasp function after stroke. So this relates back to our principles of neuroplasticity. We need to have a lot of repetition and a lot of practice in order to have improvements. And adults and audits of rehab demonstrate that stroke patients only receive a few dozen upper extremity repetitions during therapy sessions. So again, it's important to give them homework and give tools to continue to work on therapy continue to work on exercises outside of therapy. So in terms of patient engagement, there is a free exercise manual, photos, videos on the website that you have access to. And not just does the program give exercises and activities for patients to perform, some really good counseling and coaching to patients and caregivers, acknowledging that this is difficult. So this is just an example of some of the coaching scripting that they have promoted. Coaching is, when you have a stroke, some of the brain pathways are changed and are damaged, and the brain will now try to use other brain pathways. However, thousands of repetitions need to be practiced to get these brain pathways active. The GRASP program will help you activate the key arm and hand muscles so your brain can relearn how to control the muscles. It can be frustrating to practice difficult exercises over and over. However, research has shown that the ability to repair the brain is greatest soon after stroke. So there's good messaging to help explain in layman's terms why it's important to exercise. Participants whose caregivers engage in the teaching of GRASP have better outcomes. So there's some nice coaching for caregivers as well. They are encouraged to work with the patient to set goals for using their arm during the day, as well as set up the activities and help log the activity. So, it's just a great program with a lot of good tools. I think this is... if you haven't gone yet, please go and check it out. I'm going to give you just an example of some of the activities that are included in GRASP. There are 3 separate booklets to help patients with different ability levels. So lower level abilities would start with the first program, and then they would progress through the programs. And the activities focus on range of motion, strengthening, weight-bearing exercises, functional activities, and fine motor skills. And these are just a couple examples of the activities that are included in the program. So this is just push-ups. It's a weight-bearing activity for the arms to try to get some weight-bearing as well as some activation of motion in the arm. The next progression of that would be chair-ups. So if you can push up from a seated position, kind of leaning forward and pushing back, then you might try to do push-ups using your arm and weight-bearing to stand. And then the final progression is some really fine motor activities like cutting putty and handwriting and putting toothpaste, I think, on a toothbrush. So some really good things. This is the equipment list for GRASP. So not only are the exercises outlined, but also the exact equipment that would be needed. So that is GRASP. Acronym for its use are equip the patient with GRASP book and equipment, coach the patient on how to do the GRASP exercises, log the exercises, involve family and caregivers, progress the patient weekly, so exercises are always challenging. And that's the key. It's one thing to deliver exercises, but the role of the therapist is really to continually progress them so they continue to be challenging. And then support the patient, check weekly logs, and then encourage and set targets for the stroke-affected hand, acknowledging that it's difficult, but encouragement has been shown to improve outcomes. So that's GRASP. We're going to now talk about the Otago program. So switching gears a little bit, Otago is a program, a series of 17 strength and balance exercises that have been prescribed to be initially delivered by a physical therapist and then transition to a home program over time. And I'm going to just let you kind of look at these. These are just some nice functional activities that we use with patients all the time. But the Otago program really works the patient through progressions of more progressively difficult tasks. So the example is, supported knee bends to unsupported knee bends, knee extension without a weight, then knee extension with a weight, sit to stand, moving from using your arms to not moving your arms, and then a transition of sidestepping to circle 8 walking. So hopefully you can see that the role of Otago is really to address balance and strength and standing. The last program that's included in Movement Matters is LIFE, and LIFE is an exercise program that patients and caregivers and therapists can order online that really walks patients through strengthening activities incorporated into daily functional tasks. And it's designed to reduce falls and improve function, and it uses traditional dual task training to improve overall function and balance. Initially, it was described as safe for just non-neurologically impaired patients, but it has been demonstrated to be safe for stroke patients as well. And these are a couple examples of the type of activities that patients can do following the LIFE training videos and LIFE pamphlets. So sit to stand, again, with using some good extra pressure on the impaired leg. So hopefully it's helpful. Hopefully you can see a theme that we're trying to challenge patients intensely, but also give them some activities to do on their own. The context of stroke rehab, before we jump into technology, I do want to highlight that there are some tricky spots with stroke rehab that trip us up. And when we're working with patients, getting them up and walking, one thing that often comes up is the question is, how do we handle hemiplegic shoulder or subluxing shoulder? Because this can be difficult, can be painful, and it can slow and impair rehab. And it's nice, the American Heart Association, American Stroke Association has put out guidelines for how to address or how to best manage the hemiplegic shoulder. It's described that neuromuscular electrical stimulation can be useful in stimulating the muscles and preventing subluxation, as well as some supporting devices. So slings or other positioning devices. And if you've worked in stroke rehab for a period of time, you know that this is a forever debate. Do you put a patient with a hemiplegic shoulder in a sling or do you not? The reason not to do that is because if the sling doesn't fit well, you can have the humeral head kind of pushed up into the acromion and you can get impingement of structures and actually make pain worse. So the guidance from American Heart Association, American Stroke Association is that it may be appropriate to use them, but make sure that they are well positioned. The patient is well positioned in whatever device there is. And there are some good slings out on the market now, Give More, that really help patients have support for that upper extremity, so it's not hanging down while they're walking, but don't over approximate the shoulder joint. Then prevention of falls, and we recognize that as we get patients, as we get stroke survivors, as anyone gets more mobile, even ourselves, as we go out and do more challenging tasks, our risk of falls is greater. And the guidance is that every stroke patient should have comprehensive education on falls risk reduction, and Dr. Gusick has already addressed that this morning. I'm mentioning it from the rehab perspective because sometimes we do a really good job with this when the patient's in the hospital, when they're in inpatient rehab, maybe even acutely when they go home. But over time, as we talked about, the patient continues to change, and we might need to readdress falls risk and readdress strategies to reduce falls. So if you are working with someone who's had a chronic stroke, it may be appropriate to refer them back to therapy or start therapy again to address falls reduction. And these are, again, just some guidelines from American Stroke Association, American Heart Association on falls. So we talked a lot about community exercise, and now I'm going to jump into a little bit of how we're using technology to really kind of push the limits on stroke rehab. And the first kind of thing that's on the cutting edge is robotics. Robotics refers to a mechanical device, external device that has power. So these are powered devices that help facilitate movement. We talk about neuroplasticity. We describe that it's important for a patient to practice intensely and practice a lot. And sometimes that's just difficult when the patient has significant mobility deficits. So robotics can be used to allow the patient to increase the number of repetitions, reduce the number of therapists needed to require the task. They may provide more accurate feedback if the patient is actually practicing the task in a more normalized way. And they may, again, allow the opportunity to practice real-world tasks otherwise not possible. So we're going to jump out, and I'm going to let you just look at, just to show a video of one of the first robotic devices that became available for us, and that is, hold on. And that's, there are several, but these are basically body weight supported. They facilitate body weight supported treadmill training, but the device actually has robotic legs to help advance the legs for the patient. I'm just gonna show this to you. Folks haven't seen it already. This is a Locomat.
It's a robotic-assisted bodyweight support.
There are other similar devices.
Training, where you can manage different variables such as bodyweight support, guidance force, the speed, to make the activity challenging for the patient and variable as well.
The Locomats are intended to help patients who have a great degree of weakness or a great degree of asymmetry in their walking learn to walk again.
I'm not going to play the whole video, but hopefully you get the idea that they facilitate walking in a more normal pattern. And if someone's on the treadmill, they can practice many repetitions. And the therapist's role at that point is just to modulate the input given to the patient. So that is Locomat. I'm going to just go. So kind of the next generation of lower extremity robotics is exoskeletons. Exoskeletons are wearable robots, essentially, that were first developed by the military. They were designed essentially to help soldiers carry heavy loads into battle or heavy equipment into battle that they wouldn't otherwise be able to carry. So they were externally powered, and this slide just nicely shows you the generation or evolution of exoskeletons that are still being used in the military. And the exciting thing for rehab is that some of this technology is coming to us. On the far right of your slide, you have the Locomat. Then you can also see a wearable exoskeleton, and essentially the patient doesn't have the ability to perform the test themselves, so they can put on the suit and get some walking practice, similarly to the Locomat. The thing I want to highlight is that when lower extremity robotics first came out, they really weren't, while they allow the patient to practice walking, they were maybe the evidence didn't support them to be as effective as we thought they might be, which was a surprise because patients were getting tons of exercise walking in the robot. But what came out was, well, walking is a task that really involves interaction with the environment. The patient taking steps forward and kind of catching their balance and rebalancing themselves repeatedly. So that's where we think there's some great potential with exoskeletons, because the patient may have opportunity to more real-world practice the task. And again, this goes back to specificity of training. Walking on the treadmill is not the same task as walking in the environment. So we're going to just jump in to see some walking in an exoskeleton.
Everyone deserves to live their best life. If you can't walk, we want to help you learn to walk again. Exo is a robot that you can wear that provides power to the legs. Exo is FDA cleared to help physical therapists treat people recovering from stroke and other conditions that have caused them to lose their ability to walk. Every design choice in Exo was made with one goal in mind: create a rehabilitation goal for PTs to help you get more and better steps. Exo has adjustable hardware to make sure it can fit all kinds of patients quickly.
So that is Exo. And I think the really exciting thing about robotics is they're changing quickly and they're getting much less expensive, much lighter weight. These devices right now are only available in rehab centers. A patient wouldn't go home with an exoskeleton unless they had a lot of money. I know the cost for the exoskeleton is probably, in the range of $150,000, $170,000. The treadmill walking devices are much more than that, so there are not very many in the country. So these things came out initially, and they were great, but not accessible to everybody. And I think we are getting better, and I think more and more of these devices are going to come down in price and maybe be options for our patients' real world. When we talk about robotics, we'll just reference upper extremity robotics. So they're similar devices, powered devices that allow patients to practice tasks, either real world simulation, kitchen or environment, but then also maybe gaming through a a virtual reality system. So these are upper extremity robotics, and again, there are many on the market, but again, they are powered by an external battery or external engine. Here I've just got an example of a mobile arm support. So this is just a passive support. It doesn't have any power, but it basically allows the patient to be positioned in a way that he can be successful with the reaching task. So it might eliminate some of the pull of gravity, just supports him and allows him to practice a task that he wouldn't otherwise have the opportunity to practice. So again, it's just a way of getting more intense practice and helping practice be more engaging and successful. In terms of technology, we're also getting more and more savvy with our electrical stimulation, and these are just two examples of devices. On the left-hand side of the screen, you see just something with two little patches and an engine, and that's an electrical stimulation device to prevent glenohumeral subluxation. So that's E-stim for the shoulder. We just talked about American Heart Association, American Stroke Association guideline that E-stim might be helpful in treating a subluxing shoulder. And so someone's gone out there and put together a nice device, something that's wearable to patients that they could put under their clothes and really get some good benefit from. The other device is the power couple that combines biofeedback with electrical stimulation. So in rehab, we do use electrical stimulation to stimulate muscles that patients can't otherwise contract, but this device actually includes some element of biofeedback as well. So it senses when the patient is inputting the motion, and it regulates the E-stim to match the amount of activity or regulation that they need, or stimulation that they need. So neuroprosthesis. So neuroprostheses are basically splints or devices that have some electrical stimulation component. So this is BioNES. BioNES is an upper extremity neuroprosthesis that patients use to have better hand function. So again, it's an orthotic with electrical stimulation and allows for more freedom of movement than that patient might have otherwise. On the right-hand side, you have lower extremity BioNES. There's also a walk aid, which is a similar device, and it basically masks or provides the function that an AFO might provide by facilitating dorsiflexion. But it's going to facilitate muscle activation to get dorsiflexion so patients don't need to wear a brace, which is important for maintaining range of motion and potentially minimizing spasticity and preventing other consequences, negative consequences of wearing a brace. We're going to talk about a couple more cool things that are out there. So neurostimulation is another kind of really on the edge technology for stroke rehab. There are different types of neurostimulation. There's transcranial magnetic stimulation, transcranial direct current stimulation, high definition transcranial direct current stimulation, and essentially the methods of delivering stimulation to the brain to target specific areas to try to increase activity in that area. And evidence supports that increasing activity in that area while a patient is practicing a task can help drive neuroplasticity and recovery of function. So I've included just a reference on the bottom of this slide. The Shirley Ability Lab is working on some good research on the device actually in this image, which is the brain box. So this is kind of like, again, the next age of technology for stroke rehab. Last thing we'll chat about just briefly is brain orthotic interfaces. If you go out and search brain orthotic interfaces, again, this is getting more and more press, and there are more successes. These devices are really just experimental at this point, but essentially what this is just an EEG sensor that picks up EEG signals and is able to translate them into a message that can then command a device, an orthotic device, so that through mental practice, patients might be able to begin to control their environment. So this is what's out there in terms of the next up-and-coming technology. The last video I'm going to show is something that's really maybe available to all of our patients. So we've just reviewed some high technology that is very expensive, and some of it's still experimental. I think the really exciting thing is that there are more and more devices that might facilitate rehab, make activities engaging, that are affordable to patients. One is a music glove, and then the other is just more virtual reality devices. They're virtual reality systems that you can pick up for $300, which in the scope of stroke rehab equipment is pretty inexpensive, that can allow patients to practice tasks, get lots and lots of repetition of tasks in a maybe more meaningful and engaging way. So again, we talked about the fact that after stroke, sometimes patients have a lack of energy, maybe there's depression and other challenges with motivation, and we want to try to make rehab as engaging as possible. So the gentleman on the right-hand side is practicing a soccer game just through a TV interface. On the left-hand side, the woman actually has a headset and is performing a bimanual task. I'm going to show you just a quick video of the music glove, which is something, again, that's pretty exciting tool for stroke rehab.
The music glove it's a device you can wear on your hands. It'll help you recover hand movement ability if you use it to practice movement. And what it does is it senses when you make different grips, like a key punch grip or a pencil grip, and then you use that to play a really engaging musical computer game. So you're essentially practicing grips and playing music as you do it. So it's a very engaging way to get better at moving your hand. I don't use computers. It was a piece of cake. Bye.
So it's cool. This information's out there. But hopefully, again, you get the idea that if you can make it fun and interesting and use technology that's not that expensive, we hope that we can accomplish our goals, neuroplasticity and training, in a way that engages patients. The last thing we'll chat about is just activity counseling and community exercise. There's been a lot of good research and support that this is important. Cardiovascular fitness training should engage large muscle groups daily. Shorter bouts of activity can add up, so we want to encourage our patients to do whatever they can, even if it's just 5 minutes at a time, and then eventually try to get to 10 minutes and then 30 minutes daily. Activity can be home-based, outpatient-based, and ultimately should be, ideally it could be in a community group. And the American Heart Association supports that engagement in a community exercise program for 4 weeks of duration has significant benefits in improving depression. So again, we think about what we're trying to accomplish big picture for our patients, our stroke survivors. This is important to get folks out and participating. Regular activity counseling is one of the most powerful health promoting practices that healthcare professionals can recommend for patients. Sometimes this may seem difficult if your patient comes with significant disability, but we can find and do find creative ways to get our patients with stroke up and moving. No other single intervention or treatment is associated with such a high diverse array of positive benefits. And again, 4 weeks of exercise can have significant improvements in terms of depression, and that physical activity counseling should be promoted by all care providers. And just with that said, we try to think about physical activity counseling or physical activity in general as one of the 6 vital signs, and therefore we want to talk about it, want to promote it, and we want to document what our patients are doing. And the ultimate goal with our patients with stroke living longer is to include them in the community and make activities engaging. We talked just a little bit about comprehensive post-acute stroke services, the program that's gone out throughout the state of North Carolina. And you don't have this slide in your slide set, but please know that if you can just follow this link and get a pop-up to many resources that are available to your patients. If you go into the website, you can key in your zip code and just understand what resources in terms of community exercise are available to stroke survivors. So if you're working with folks anywhere in the state of North Carolina, I encourage you to go out and see what's available in your community. I'm going to take a little bit of creative liberty here and show just one last video, but I think it really encompasses kind of the heart of what we're trying to get at with engaging patients in activities and the community. This little guy has not had a stroke. But again, I think this captures the spirit of what we try to do in rehab. So that's a cool example of how we can be innovative in something that's low tech. So we talked about high technology, low technology, and the point is just to engage. So that is that. At this point, are there any questions? Yes. Mm-hmm. We have had stroke patients receive it, but someone over here just said no.
There are limitations for what we've been able to do for rehab for our patients. So we're trying to be innovative at following what the studies got. There's also limitations to people who have no money.
Right. So the response is that there are limitations, but I think it really depends on your insurance, and so it's worth a try. I wouldn't count it out necessarily.
That's getting tighter and tighter, but I have found that the Altago exercise link is really great. It's in the conference website, but you can pull 91 pages off that. Get it in and make copies for what's important for your patient individually. I think that's been very helpful.
So the comment is just that that the Otago exercises have been very helpful for patients who may not have resources. But I've given you a lot of different tools, understanding that some patients have good resources, some patients may be able to get funding from a community program, and there are many potential resources. So don't count something like BioNess out, but also know that if your patient can't get that, there are other ways to get it at intensive practice, and that's the point of really promoting Otago, Life, and GRASP, because those are things that patients can do on their own outside of therapy. So we try to be comprehensive. We have certainly heard stories of people not maybe getting the services that they need, or people, therapists backing off on providing really intensive care because we didn't have, ABC or XYZ piece of equipment. And we wouldn't ever want to do that. We can always try to be creative and come up with ways to get the best practice, because many of us practice in environments that don't have the latest, greatest devices. But again, you can get intensity of practice in many different ways. These are just different ways to get at neuroplasticity and practice. And again, you can do that lots of ways. That's a great question, and that's always a question. Is this actually going to get paid for? Questions?
About the exoskeleton, you said there's only a few in the country.
Mm-hmm.
Do you know if there's one kind of close in our area or on the East Coast?
Yeah. So Locomat is the partial body weight support treadmill walking device, and that there are about, probably 50 to 100 of those in the country. There is one, Carolinas Medical Center does have one, so that's there. But with the exoskeleton is the wearable device, and there are more and more of them. In fact, High Point University has one, and they have a free clinic for patients, and they are always looking for patients to come and participate in their programs. So that's actually available for free. They have one as a research group that has a free clinic to help train their students. So yeah, and they have Exos.
I think Winston State has a program as well for our area, but I wasn't fully aware of the High Point.
Mm-hmm. Yes. Mm-hmm. So the comment is Winston-Salem State also has a free clinic for patients. Okay, thank you. Oh, sorry, one more question.
I'm just curious, are you doing anything creative to get patient or family buy-in, like the motivation part? Are you doing anything different, or what's kind of new? Because that always seems to be difficult to either get the buy-in or have them continue kind of the momentum when they think you're.
I think that's a great question. The question was, are we doing anything different to try to get family buy-in? We certainly are using strategies, behavioral interviewing strategies to try to focus on goals. Feedback that we get as a profession is sometimes we're overwhelming. We give patients too many things to think about, too many things to focus on. So, in behavioral interviewing, we try to focus on, well, what is your primary goal? And then focus on that. I think the other thing that's motivating is just some of the lower technology things that we can do to actually make it doable. Because I think caregivers get overwhelmed when we give recommendations that they feel like they just can't do. So and the other thing is just involve them in therapy and give them time to practice. I think simplifying it as much as possible is important, and then giving them the resources, because sometimes they don't know what the options are. So for the Compass website, which is one of the last slides I showed you, that has resources for caregivers as well, and which also includes respite care, so giving people a break when they need that.